Hello, everyone. My name is Haidira del Rivero. I am a medical oncologist and also an endocrinologist that specializes in neuroendocrine tumors. Today, we're going to discuss about the hormonal basis and medical oncology approaches for the treatment of neuroendocrine tumors. First, we need to understand a little bit about the disorders of the endocrine system and also understand what that means when a patient has hormone excess or hormone insufficiency. Hormone insufficiency is when there is a specific hormone that is produced very little, or hormone excess when a specific hormone is produced in an excessive amount. The body usually produces a specific amount of hormones needed for our day-to-day functions, but sometimes when there is insufficiency or when there is a hormone excess, then also produces very specific signs and symptoms that often will need to be treated and be seen also by endocrinologists who specialize about the endocrine system. First, let's discuss a little bit about the hormone excess. The neuroendocrine tumors, as we know, and just Mike, let me just reward this a little bit. I hope you can make some changes here. I'm sorry. So let's just talk a little bit about the hormone excess. So neuroendocrine tumors, as we all know, there are very specific and very unique group of neoplasms that also have the capacity to produce hormones or excess of hormones. I will advise as well that you can also listen to many of the videos that NCAN has in their library. At the same time, I will advise you also to attend the different conference that NCAN is also planning throughout the year, where they can describe more in detail about neuroendocrine tumors and how do we treat neuroendocrine tumors, especially for those who are newly diagnosed. But just a little bit of a background, neuroendocrine tumors are a very unique group of neoplasms that have the capacity to produce hormones, as I said earlier. Also, neuroendocrine tumors, the way they're called neuroendocrine tumors is because they have very specific markers that is look into the microscope. One is anetophysin and the other one is chromogranin. But at the same time, neuroendocrine tumors, the endocrine parts, because they also have the capacity to produce certain hormones. Neuroendocrine tumors can be anywhere in the body. Depending on where the neuroendocrine tumor is located, they can also produce very specific hormones, and depending on what hormones the neuroendocrine tumor produces, it can also have very specific symptomatology and also different ways that we can treat. As we can see here, there are different neuroendocrine tumors throughout the body. For example, the neuroendocrine tumors of the thyroid is called medullary thyroid cancer, produce a hormone that is called calcitonin. And calcitonin also may have a different set of symptoms. Most common neuroendocrine tumors throughout the body are either on the gastrointestinal tract, which could be the small intestine, as well as pancreas, as well as the lung. We're going to discuss a little bit more in details, mainly focusing on the neuroendocrine tumors of the gastrointestinal tract, what hormone they produce, and of course, what symptoms may be associated with that. Most of the neuroendocrine tumors, for example, in the pancreas, they are non-functional, meaning they don't produce hormones, but the 30% may produce a very specific hormones. And as we can see here, depending on what cell is affected within the pancreas, they can also produce a very specific hormones that produce very specific signs and symptoms. And we're going to discuss more about that. Now, let's focus a little bit about the neuroendocrine tumors of the gastrointestinal tract, or the GI nets. More than 90% of patients with carcinoid syndromes involve the liver with primary tumors in the distal small intestine or proximal colon. Most of the neuroendocrine tumors in the gastrointestinal tract, the reason why they can't cause this syndrome called carcinoid syndrome is because they have also the capacity to produce these extra hormones. This hormone is called serotonin. And we're going to talk a little about what that means. Serotonin comes from tryptophan. So tryptophan is an essential amino acid, and that tryptophan comes from the diet. Whenever we had certain food or that is then ingested, so in form of a tryptophan, like I said, it's an essential amino acid, then tryptophan then is metabolized through a a part of the small intestine, and this is kind of like looking into we kind of like select a very specific type part of the body. In this case, it's small intestine. So whenever the tryptophan is then ingested, is then processed by a very specific group of cells, which is the enterochromatic cells. And the enterochromatic cells is a type of neuroendocrine cells, which is very important for the gastrointestinal regulation as well for intestinal motility and secretion. So once the tryptophan is ingested, it goes then into the enterochromatic cells, and then tryptophan is then converted to serotonin by an enzyme called tryptophan hydroxylase, which is also here localized in the enterochromatic cells. Then once it's converted to tryptophan, then the way it's then measured in the urine via 5-HIAA is when then subsequently is metabolized primarily in the liver. So once it's converted to tryptophan to serotonin from this enzyme called tryptophan hydroxylase, then it's synthesized and metabolized then in the liver, and then via 5-hydroxyinteroacetic acid, and that's the one that we measure in the urine or now in the serum as well. So in terms of understanding more about the serotonin and neuroendocrine tumors, as we discussed, a little bit of where it is coming from, that is come from tryptophan that converted serotonin via the tryptophan hydroxylase and then metabolized in the liver. And that's how we're able to measure either in the urine, the blood via 5-HIAA. This excess of hormone that is produced by the neuroendocrine tumors can produce a series of symptoms. The most common symptoms that we have seen associated with this is flushing, diarrhea, shortness of breath, as well as palpitations, some wheezing, but also understanding that this excess of hormones can also cause some long-term complications or some complications related to this. And we're going to discuss more about details, but the complications that we have seen related to excess serotonin is, for example, the carcinoma heart disease. We're going to talk a little bit about that. Mesenteric fibrosis, meaning when there is a scar tissue around the small intestines and the layer that covers the intestines as well. It can also cause other signs and symptoms like some neuropsychological disorders, carcinoid crisis, and we will definitely talk a little bit more about that. Tryptophan, like I said, is an essential amino acid, is important for growth in infants as well as maintenance of certain proteins in the body, muscles, as well as certain enzymes and neurotransmitters as well. But always, as I say, if there is a neuroendocrine tumor that produces excess of serotonin, that's because this tryptophan that is ingested is immediately metabolized, but this excess of serotonin from the small intestine and then subsequently cause the symptoms that we just discussed. So the effects of elevated serotonin, it can also cause what some of us know as carcinoid syndrome, but this excess serotonin is also known to be responsible for the tumor growth. So some of the important parts of the therapy is that it's important to not only recognize the symptoms related to excess serotonin, but as well as also how do we treat these symptoms that can also help us as well, not only alleviate the symptoms with the adequate treatment, but it can also help us as well to slow down tumor growth. And we'll talk a little bit about that. So carcinoid syndrome is a group of signs and symptoms related to excess of serotonin. Most common symptoms associated with carcinoid syndrome, for example, are flushing and diarrhea. And those symptoms can be quite debilitating. As we can see in this graph, and I'm sorry that is covered by a black box, but just to mention that the one on the bottom, that's the most common symptom associated with carcinoid syndrome, which is flushing and as well as diarrhea. And that's the ones that can, as I said, can be quite debilitating, and the ones that we need to recognize and as well as treat adequately. Other symptomatology associated with carcinoid syndrome can also cause shortness of breath. It can also cause some wheezing. This excess of serotonin can also accumulate on the heart valve and form like some type of scar tissue as well in the heart valve, and that can also cause what we call carcinoma heart disease because it can affect some of the valves in the heart. This excess serotonin can also accumulate in the liver, can cause enlargement of the liver as well, and it can also, this excess serotonin can also accumulate around the small intestines, and as well the lining that covers the gastrointestinal tract, and that can also cause fibrosis. This type of scar tissue could cause fibrosis, can cause pain as well, and sometimes in those situations, in order to alleviate those symptoms, they need to undergo surgical intervention. There are the symptoms related to diarrhea. Most of the times it's related to serotonin, but flushing, serotonin is not the only hormones that may be associated with flushing. There's other hormones as well that has been associated with flushing, such as the histamine, kallikreins, and those are the other hormones as well associated with that. And sometimes when we have a patient that have a lung neuroendocrine tumor, sometimes can be associated with excess serotonin, but sometimes it can produce this excess of histamine that can produce these flushing as well as wheezing symptoms. And those can also needs to be recognized, because there may be other measurements in terms of treatments that will need to be recommended as well. Another aspect of the serotonin syndromes, and we have learned as well, is can be exacerbated by the 5 E's. The 5 E's stand for E for epinephrine, E for eating, E for emotions, E for ethanol, and E for exercise. That said, it is important to acknowledge and recognize it, but that doesn't happen to everyone. I usually tell my patients, you just need to live your normal life. You need to eat what you like to eat, but also recognize what of the things that you do may exacerbate some of the symptoms related to serotonin syndrome. There are certain foods that can do that, and that's why here, and there's some of the foods that are highest in the highest on the tryptophan content. Like I say, tryptophan is essentially amino acid that converts from tryptophan to serotonin via this enzyme. So sometimes it's the thought that if you eat certain foods that may have this excess of tryptophan, could that exacerbate the symptoms? Maybe, but it's something that we know that we need to recognize, but that doesn't mean that you need to deprive yourself of some of the things or some of the certain aspects of foods that you enjoy. So you just need to know that they may be, and then just acknowledge if there may be certain or may exacerbate some of the symptoms. And if that's the case, you either avoid it, or sometimes just by using a short-acting octreotide before having the things, even a glass of wine, that may also help to ameliorate some of the symptoms related to serotonin syndrome. Like I say, ethanol, can also exacerbate some of the flushing. But like I say, if that's the case, sometimes some of my patients, they enjoy a glass of wine. And if that's the case, maybe we can use a short-acting octreotide prior to the glass of wine so that we can minimize the symptoms. I think it's important that you discuss with your doctors what symptoms you have, in which conditions, and depending on that, we can make some adjustments and what needs to be done. But that say, we also don't want you to deprive the things that you enjoy. You like to exercise and do like a long hiking. We just plan with you what needs to be done prior. That then recognize and see what may exacerbate some of the symptoms. If that's the case, we can then discuss what measurements we can recommend, so that way you can still enjoy the things that you do. Now, carcinoid syndrome diarrhea occurs in approximately 80% of patients, and is often the most debilitating component of the syndrome. Stools may vary from few to more than 30 per day, are typically watery and non-bloody, and can be explosive and accompanied sometimes with abdominal pain or abdominal cramping. The abdominal cramps may be a consequence also of the mesenteric fibrosis. So the mesenteric fibrosis, when there is this excess of hormones that can cause scar tissue around the small intestine, and like I say, the layer that covers the intestines, that can also cause some pain. It can also cause some obstructions, but that can also needs to be discussed with your primary or your treating physician, because there may be certain things that will need to be done in order to prevent some of these symptoms. And diarrhea is usually unrelated to the flushing episode. It doesn't mean that you have diarrhea, you will have the flushing, or vice versa. So, but it's, again, like I said, important to recognize the symptoms too. So one of the main therapies that can help to help to slow down growth of tumors, but at the same time can help to control the symptoms related to hormone excess is this group of drugs called somatostatin agonists. It's either lanreotide or octreotide. These are the injections. So we have the long-acting injection, which it could be lanreotide, but there is also the long-acting octreotide, but there is also the short-acting octreotide. We don't have a short-acting lanreotide, but we have a short-acting octreotide, which is a smaller dose, and it can be given 2, 3, even 4 times a day. So as I mentioned earlier, most of the neuroendocrine tumors do express somatostatin receptors in the surface of the cells, and because of the somatostatin receptor, these therapies can also be effective because it targets those receptors. It's important because it can also have an effect on controlling the tumor growth, but at the same time control the hormonal production. And like I mentioned earlier, there are 2 forms of the somatostatin agonist, either lanreotide or octreotide. There is really not a head comparison that tells me which one is better. We always say that they're equivalent. I think usually whatever the insurance is able to approve, but the 2 of them are equally effective for the treatment of the hormone excess as well as control the growth of tumors. So what other interventions are recommended or needed in order to control the symptoms related to hormone excess, especially diarrhea? As I say and mentioned, diarrhea is one of the most common symptoms. It's usually the most debilitating symptoms related to the serotonin, the carcinoid syndrome. There is now medication that is approved by the FDA for the symptoms related to carcinoid syndrome diarrhea, and the name of the drug is called telotrestat. So this is a figure which tells me how telotrestat works. I think I mentioned earlier, and I mentioned again, that the tryptophan is converted to serotonin by enzyme called tryptophan hydroxylase. And the telotrestat, what it does, the drugs blocks the enzyme, which is called tryptophan hydroxylase. That's what the telotrestat do. It blocks the rate-limited enzyme, so there is less production of serotonin, and because there is less production of serotonin, is also cause less excess of 5-HIAA that we can measure in the urine, and as a consequence, it can also cause less symptoms related to carcinoid syndrome diarrhea. This is just a study that was done for the approval of telotrestat. Like I say again, telotrestat is a drug that blocks the rate-limited enzyme of the conversion of tryptophan to serotonin, so that there is less serotonin production. And as we can see here, so we can see in this graph, we can see the measurement of 5-HIAA of the patients that were enrolled on the study. We can see that the patients, it was a randomized study, patients either receiving the drug or receiving placebo. The patients that were in placebo, they did not see a decrease on the levels of 5-HIAA, but we can see here in this graph, the more the negative number, the more the decrease of the 5-HIAA. That's by using the drugs. They also have the less of the measurements of the 5-HIAA. Moreover, as we can see here in this graph, patients that were in telotrestat has less episodes of diarrhea compared to the patients that were on placebo, meaning that were not receiving the actual drug. The patients that were receiving the telotrestat, they can also see that the numbers of bowel movement also decreased by using this drug, and because of that, that was subsequently approved for by the FDA for carcinoid syndrome diarrhea. Now, there is an ongoing study, too, of another drug that is also very similar, works like the injections such as lanreotide or octreotide as a somatostatin agonist. Paltusotine is another type of somatostatin agonist, but it's an oral form. So we have known about lanreotide or octreotide that is a form of an injection. This one is an oral form, and it's called paltusotine. And paltusotine was the results of the phase 2 study, was presented in one of the medical conferences specific for neuroendocrine tumors. That patients that receive paltusotine also have a significant decrease on the symptoms related to flushing and diarrhea. And there is an ongoing phase 3 study of the study, and the hope is that based on the results, it can be approved by the FDA, so that way it will be subsequently available for other patients, another option as well that can help for the symptoms related to serotonin excess. Now, another complication related to serotonin excess is carcinoma heart disease. As I said earlier, this excess of hormones can also accumulate in the heart valve. So this square is, imagine this like a representation of your heart. So and you have on the right side of your heart, you have what we call the two different valves, the tricuspid valve as well as the pulmonary valve, and on the left side of your heart you have other valve. And as we can see here, the excess of serotonin, that mainly comes from the liver metastasis. This excess of hormones can also it goes into circulation and accumulate in the heart valve, and that can also cause long-term chronic exposure of these hormones can also cause carcinoma heart disease. And some of these patients may need to have heart valve replacements because sometimes the scar is so severe that sometimes in order to really control some of these symptoms, we need to undergo surgery with the replacement of the heart valve. That's one of the reasons why every patient that is known to have small bowel neuroendocrine tumors with excess of serotonin, is important that they see a cardiologist. They need to have an echocardiogram, as also they need to have certain measurements in the blood. We are learning now that there is a specific blood test that we measure. It's called the pro-brain natriuretic peptide, the pro-BNP. This is a protein that is also produced by the heart, and in patients that have carcinoma heart disease, sometimes we see an elevation of this. It can also be as a screen for patients that have carcinoma heart disease, but also patients that have elevated 5-HIAA. It's important that they see a cardiologist, so that way they can have evaluations and do also an echocardiogram. Timing is still questionable, depending on the level. Sometimes it could be every 6 to 12 months or every 2 or 3 years, depending on how high the 5-HIAA is reported. But that's an important aspect to recognize about this excess of hormones, and that needs to be treated and followed as well by a cardiologist. As we discussed, the lotristat is a medication that I mentioned earlier. It blocks the rate-limited enzyme of the conversion from tryptophan to serotonin. And that has been approved by the FDA for the symptoms related to carcinoid syndrome, diarrhea mainly. But there is an ongoing study that it may also help prevent the carcinoid heart disease. And it will make sense, right? Because we know that this medication also lowers the excess of serotonin. So maybe by lowering this excess serotonin, that can also may not have these other effects that we discussed as just the carcinoma heart disease. It's an ongoing study. Some centers within the United States have this study available. So in summary, it's important to know that patients that have small bowel neuroendocrine tumors and some of the lungs neuroendocrine tumors may produce this excess of serotonin. This excess of serotonin is a driver of carcinoid syndrome. Excess serotonin plays an important role because, as we discussed, it can be responsible for the development of carcinoid heart disease as well as mesenteric fibrosis. It can also cause the pressure around the pulmonary arteries too, because again, this serotonin causes scar tissues around some of the pulmonic valve, and that can also increase the pressure. That's something that needs to be keep in mind. Serotonin also has been demonstrated to have effects on tumor growth, and it's important to control the exposure of serotonin, because that can also improve the quality of life as well as patients in the prognosis of patients with carcinoid syndrome. Now, we discussed about excess hormones related to serotonin in a patient either with a small bowel neuroendocrine tumors, and also can happen with lung neuroendocrine tumors. Now let's talk about pancreas neuroendocrine tumors. So up to 30% of pancreas neuroendocrine tumors also secrete hormones, and depending on what hormones they produce may also result in clinical syndromes. There are, and we call that functional pancreas neuroendocrine tumors. So what are those functional pancreas neuroendocrine tumors? Like again, depending on what cell is affected within the pancreas, they produce very specific excess of hormones, and they can cause symptoms. For example, an insulinoma is a patient that has usually a pancreas neuroendocrine tumor that produces excess of insulin, and this insulin is responsible for lowering the blood glucose in the body. So if you have this excess of insulin, it's going to certainly lower all of the glucose, everything that you eat, everything that may raise the glucose. This excess of insulin is certainly going to lower dramatically, and then you have symptoms of hypoglycemia, and we're going to discuss about that, or low blood glucose. The same gastrin. Gastrin is another hormone produced by the pancreatic cells. Gastrin is responsible for the regulation of acid in the stomach, and this gastrin can also stimulate more of the acid in the stomach, and because of that, it can cause ulcers, it can cause severe diarrhea. These ulcers can sometimes perforate because of the excess of gastrin. That's called Zollinger-Ellison syndrome. Those are the most that we have seen in terms of functional pancreas neuroendocrine tumors. Other hormones such as VIP-OMA. VIP is the name of the hormone, is a vasoactive intestinal polypeptide that regulates a lot of the electrolytes in the body. If there is an excess of that, it causes profound diarrhea with loss of electrolytes. Glucagonoma is also very rare, but it can happen. And glucagon, it can also regulate the insulin secretion. So we have, I discussed earlier, the excess of insulin lowers the blood glucose, and that can happen in certain type of pancreas neuroendocrine tumors. But glucagon, excess of glucagon prevent the insulin secretions, and that goes the opposite. It can cause excess of blood glucose and diabetes. The other hormone is called somatostatin. The pancreas, the neuroendocrine tumors that produce excess somatostatin is called somatostatinomas. It's super rare, and this can also cause, it can also inhibit the production of insulin, so it can cause these patients may develop diabetes. It can also, this excess somatostatin, it can also inhibit some of the gastrointestinal salts, and because of that, they can also form bile stones and increase the fat excretion in the stool. So now, even though the VIP-OMAs, glucagonomas, and somatostatinomas are super rare, they can still, is important to recognize, because that way, if depending on what symptoms they have, there is always two important things that we need to know. We need to know the neuroendocrine tumors and what we need to do, to control the symptoms related to the excess of hormones, as well as control the tumor growth. And that's why there are certain measurements besides the one that we usually recommend for the treatment of the tumor control or growth of the tumor. Now we discuss about insulinoma. What is insulinoma? Insulinoma is when the neuroendocrine tumor produces excess of insulin. Insulin is responsible for lowering the blood glucose in the body. When we have this excess of insulin, patients constantly has low blood glucose, and usually the symptoms are that the blood glucose is usually less than 50, that then develop many symptoms related to the low blood glucose, such as confusion, irritation, syncope, and those symptoms are usually relieved by the high content of sugar meals, and that's what we call the Whipple's triad, and that's very characteristic of insulinoma. And when it's recognized, the best way to treat insulinoma is by surgical resection. In insulinoma, sometimes the tumors can be very small and sometimes can cause a lot of symptoms. The symptoms of insulinoma, they're very characteristic, and they can be early diagnosed. And because of that, once it's recognized, they can do the surgery. And most of the time, patients can be cured from the disease. But sometimes we have the situations that can be metastatic, and that's when other interventions will need to be done. Important when the symptoms related to insulinoma happen. So there are certain measurements that we need to recommend, like frequent small meals, meals with high content of carbohydrate. Sometimes oral glucose may need to be given. There is a medication called diazoxide that reduces the insulin secretions, but also the injections such as octreotide lanreotide, like I said earlier, has to function. It can control the symptoms related to hormone excess, but at the same time, it can also control the growth of tumors. When the patient has more of advanced disease, there are other measurements besides the monthly injections. We have other treatments, systemic therapies that I'm sure you're going to hear in these different podcasts that you're going to listen to throughout the month and the weeks to come, but also when do we do certain interventions, such as surgery and liver-directed therapy. That's also important to recognize. And that's one of the reasons why the neuroendocrine tumors is not a one-size-fits-all. The treatment is personalized from patient to patient, depending on many different clinical characteristics of the patients, where the tumor is located, where is the primary, where is pancreas, where is small bowel, whether it's lung, if there are metastases, or if there are in different areas of the body, if it's spread out, where is it, whether it's only in the liver or outside the liver, whether it expresses somatostatin receptors or not, whether it's slow growing, rapidly growing. So those are the different things that we need to discuss, and as well to understand in every patient, to then provide the best guidance on therapies. And gastrinomas, As I said earlier, gastrin is a hormone that is produced either by the pancreas as well as by this part of the small intestine called the duodenum. And this excess of gastrin can secrete the acid from the stomach, because that's what the gastrin do. The gastrin is basically responsible for the regulation and of the production of gastrin by the parietal cells, and this excess of gastrin can stimulate this excess of acid in the stomach, and because of that can also produce peptic ulcers. These peptic ulcers sometimes can bleed, and sometimes patients may present to the emergency room having what we call it GI bleeding. It can also cause diarrhea, significant symptoms just like heartburn. And in those situations, we need to give something that inhibits the production of acid in the stomach. And some of them is called what we call the proton pump inhibitors. We use it often as we get older. Sometimes, for different factors, sometimes it's needed in order to inhibit the production of acid in the stomach. But in patients that have a gastrinoma, it has to have a higher dose of either omeprazole or pantoprazole. It's not just the standard dose for a regular GERD that we call GERD, or gastroesophageal reflux disease. For a patient with gastrinoma, these patients will require much higher doses, either omeprazole or pantoprazole. For the management of advanced disease, besides the monthly injection, as we discussed, there are other different therapies, either surgery or liver-directed therapy, as well as the different systemic therapies options for the treatment of neuroendocrine tumors. Now, VIPoma is VIP, stands for vasoactive intestinal polypeptide. This is a hormone that is responsible for the regulation of electrolytes in the bodies. Whenever there is an excess of these hormones, it can cause significant watery diarrhea. Usually stools are like tea color. They're odorless, but volume can be quite significant. It could be many times throughout the day, or maybe at one time a significant amount of diarrhea, anywhere from 700 cc's to 3 liters of stools. And because of that profound watery diarrhea, they can also lose a lot of electrolytes, so low potassium, low chloride, and abdominal pain. So it's important that when this happens, recognize it, because these patients require other measurements such as repletion of the electrolytes. The injections such as octreotide can sometimes help in patients with severe symptoms. Sometimes the steroids can help too, but always important to recognize, manage not only with general measurements, but also depending if it's localized, if it's advanced, if it's localized. Surgery is usually what is recommended, and then some patients can be curative. But in the setting of advanced disease, there are other measurements such as systemic therapy, surgery that needs to be discussed with the patient. Glucagonoma is super rare. As we discussed, glucagonoma is the excess of glucagon. So glucagon is responsible for some of the metabolism of certain amino acids in the body, but at the same time, this excess of glucagon can inhibit the insulin secretions. If there is not enough insulin, then they cannot lower the glucose, so these patients may develop diabetes. So we have two different scenarios, right? We discuss about a patient with pancreas neuroendocrine tumors producing insulin. These excess of insulins lower the blood glucose. When a patient with glucagonoma or excess of glucagon inhibit the secretion of insulin. So there is not enough insulin, and because of that, it can cause diabetes. So it's just kind of like two completely different scenarios. And these patients can also, as I say, can have diabetes, but because also glucagon is responsible for some of the amino acid metabolism. Sometimes these patients may have a skin rash, and there's a very specific rash in patients with glucagonoma called necrolytic migratory erythema. It's a very specific rash. They may have other symptoms such as diarrhea. They can also form clots. They can also cause some depression, insomnia. So there's a very specific characteristics related to glucagonimas. So because of, as I say earlier, glucagon inhibit the secretion of insulin. So there is not enough insulin. So the patients develop diabetes. So we need to manage the diabetes. We need to give nutritional support, sometimes with amino acids, because as I say, the excess of glucagons can not metabolize some of the amino acids properly. And because of that, we have to give what is missing. And again, management, as well as when it's localized, surgery, but also in some of these patients, always a discussion about, even in the metastatic setting, having a discussion with a surgeon, because these patients may also benefit from what we call cytoreductive surgery. The goal of surgery in a patient with neuroendocrine tumor that they metastasize is to resect at least 70% of the whole volume of disease. And because we know that can also be associated with improvement and survival of patients with the diagnosis of neuroendocrine tumors. And of course, systemic therapies is also recommended in patients with metastatic disease. There are different types of systemic therapy, so we'll advise you to continue listening to the podcast by NCAN. I'm sure there's going to be very educational and a lot of information, of course, especially if you're newly diagnosed. And last is another very rare, this is super rare type of neuroendocrine tumors called somatostenomas. This is exosomatostatin. This exosomatostatin can also inhibit the secretion of insulin that can cause diabetes. It can also it can also alter the bile salt and some of the hormones in the gut, and because of that, it can also form gallstones and they can cause diarrhea too. And again, if this can happen, we recognize surgery is usually what is recommended, but in the patients with surgery is not indicated, so we need to recognize it, and there's different measurement as well that will need to be recommended, such as injections and as I said earlier, some of these patients may benefit from surgery or liver-directed therapy, as well as systemic therapies that you will hear throughout the series of podcasts. Now, briefly, let's discuss a little bit about thoracic NETs, because I feel like this syndrome is not as recognized as others and it can happen in a good number of patients with lung neuroendocrine tumors. So lung neuroendocrine tumors can also produce excess of hormones, not in all of them, but it can't. Some of them is serotonin, and we discussed earlier about serotonin causing carcinoid syndrome, but then a subset of patients can cause excess of another hormone, which is called the ACTH. So the ACTH is a long name, I'm going to say, and it's adrenocorticotropic hormones, which basically what it does is this hormones stimulates the secretion of cortisol in the adrenal gland. So the adrenal gland is a small gland out on top of the kidney, and if you cut the adrenal gland in half, as we can see in this picture, it has two layers. One is the inner part of the adrenal gland, which is called the adrenal medulla, but also the outer part of the adrenal gland is called the adrenal cortex. And the ACTH stimulates one of the lines of the adrenal gland, which is responsible for the production of cortisol. If you have a lot of ACTH produced by the tumor, then it's going to be excess of cortisol. And this excess of cortisol causes a syndrome called the Cushing's syndrome. So what is Cushing's syndrome? So Cushing's syndrome is a series of symptoms. This is because of the excess of cortisol. So patients with excess of cortisol may have very specific characteristics. They may have a red face. They may also have some accumulation of fat in the part of on the back of the neck. It can also has deposited fat around the abdomen. It can also cause a very specific stria, which we call purple stria. They have very specific color, as well as it's not like the regular stria. These are very specific in color as well, and how wide they are. It can also cause other symptoms such as high blood glucose, high blood pressure. Because of course it can decrease the wound healing. It can also patients at risk for fractures, and so forth. So I think it's important to recognize that this can happen in a patient with neuroendocrine tumors. We see it more in patients with lung neuroendocrine tumors. It can also happen in other neuroendocrine tumors, such as the pancreas, as well as neuroendocrine tumor of the thyroid. Important to recognize the symptoms. There is a series of tests that needs to be done in order to confirm whether the patient has this excess of ACTH that may produce this excess of cortisol. There is medical therapies for that. There are different oral therapies that can help us control the excess of cortisol, but sometimes in situations where it's very difficult to control by oral medication, sometimes we need to remove the adrenals, because even though the tumor is producing excess of cortisol, by removing the stimulus, meaning by removing the adrenal glands, there is not this excess of cortisol. So, and that's important to recognize, as well as to talk to your treating physician, because sometimes that may be needed in order to have control of the cortisol. Once we control the cortisol, sometimes it's easier than to provide other systemic therapies, because this excess of cortisol can also put the patient at risk for infections as well from clots. So that's why it's important that we need to treat this type of syndrome aggressively. There is a company called Crinetics that has an ongoing study for the excess of ACTH, and that also is for patients that have produced excess of ACTH caused by the tumors, such as neuroendocrine tumors. Now, again, you're going to hear throughout the different podcasts what is the different management of neuroendocrine tumors, especially from the advanced settings. What are the different types of systemic therapies? When do we recommend each one of them? What are those available? But important to know that the treatment of tumor as well as hormone excess requires a personalized approach. We now have different therapies, as we can see here. We have like the treatment with peptide receptor radionuclide therapy. We have somatostatin agonists, a different therapies such as everolimus, sunitinib, and cabozantinib. When do we recommend cytotoxic chemotherapy, or when to recommend surgery, or any type of liver-directed therapy? Like I said earlier, it also depends on the clinical characteristics of how the neuroendocrine tumor presents. As I say too, it's not a one in neuroendocrine tumors. The treatment is personalized from patient to patient. It's not like one size fits all, and the different clinical characteristics to then provide what we think may be the best treatment options. And that's important that we always discuss. It's important that you see a net expert, so that way they can also discuss all the treatment available and based on the clinical characteristics of the neuroendocrine tumors. And this is a summary of the hormone excess, symptom management of hormone excess related to the neuroendocrine tumors. We talk about carcinoid and what are the things that we need to do for the excess of symptoms related to carcinoid syndrome and diarrhea, which is debilitating. The other measurements I need to do with the anti-diarrhea medicines as well as tinted opioid can be used. We discuss about if there is excess of insulin, what needs to be done, VIPoma, excess of gastrin, glucagonoma. So we can see they are depending on what the neuroendocrine tumor is and what the hormone produces and excess of what hormones, there has to be certain measurements, which is also independent of the symptoms related to the advanced disease or systemic therapies. Now let's talk about hormone insufficiency, because part of the endocrine management of these tumors is we discuss about the hormone excess, how do we treat it, but also hormone insufficiency, because I know that this is something that it can happen in patients with the diagnosis of neuroendocrine tumors, but it's often not sometimes recognized or discussed. And some of them can be a side effects as well of the treatments that we recommend. For example, somatostatin agonists such as sandostatin or lanreotide has been associated with diabetes, and let me explain to you why. So the injections such as sandostatin or lanreotide, it can also block the secretion of insulin. As I say, insulin is important because it can also regulate the excess of blood glucose in your body. So whenever we eat and our blood glucose goes high, and then your beta cells in the pancreas start to secrete insulin, so that we can lower the excess of glucose, because we cannot live forever with excess of glucose, but that can also cause different complications, and that's what we call diabetes. So sometimes these injections can cause, and 27% can cause excess, it can cause diabetes, because it can block the insulin release and it can cause diabetes. Usually I see that more with lanreotide, with sandostatin, but 4% or less, it can also cause hypoglycemia. So I know that we discussed about that it can increase the blood glucose, but in a very small percentage of patients, it can go to the opposite. It can cause hypoglycemia, because at the same time, it may also stimulate this excess of insulin in certain patients, and then it can also cause the hypoglycemia. So again, it's important to acknowledge and also recognize as well, so that way we can then recommend certain measurements or adjust the medicine or reduce the dose, for example, in the case of sandostatin and so forth. Everolimus is another therapy that we have recommended for the management of neuroendocrine tumors. So everolimus has been also associated with elevation of the blood glucose levels. So it can cause diabetes, and up to 50%, 12 to 50% of patients, the use of everolimus can cause diabetes. Like I say, we discuss hormone excess, hormone deficiency, because we don't have enough insulin, right? So if that's what we call hormone deficiency, not enough insulin, because what everolimus does, everolimus also blocks the secretion of insulin, so we don't have enough insulin to lower the blood glucose, that can cause diabetes. In patients that have an insulinoma, even there's a side effect, but in a patient that has an insulinoma, is actually a good side effect to have, because like I said earlier, patients with insulinoma have this excess of insulin, and that can cause symptoms. So if we give everolimus, that can also block the secretion of insulin, and then we see this hyperglycemia in those patients as well. So something to keep in mind. So type 2 diabetes, we discuss about two potential drugs that has been two drugs that can potentially be associated with the development of diabetes. One is somatostatin agonist with injections as well as everolimus. It's important to recognize the signs and symptoms of diabetes or hyperglycemia, and some symptoms that are reported of excessive thirst, weight loss, frequent urination, slow healing, excessive hunger, fatigue, blurry vision, numbness too, because this excess of glucose, when we don't decrease it, that can also accumulate in some of the nerves, and that can also cause some numbness and tinglings in the hands and feet. And that's why it's important to recognize how a patient have these symptoms. The way we make the diagnosis of diabetes is by doing a blood test. It's called the hemoglobin A1C. The hemoglobin A1C is a blood test that tells us how your blood glucose in average in a 3-month period. So that's kind of like a way that we're able to diagnose a patient with diabetes. And then once it's diagnosed, we need to recognize and we need to treat it, sometimes with lifestyle modification, sometimes with medication, sometimes with as well as continuous glucose monitoring. One of the medications that has been used here for the management of diabetes that is now very common, a lot of people use it, is Ozempic and Mounjaro, and they use it because it can also cause weight loss. And it's a very good drug because it can certainly it can definitely cause weight loss, and it can also help at the same time manage the diabetes. And I also get the question about whether it's safe to use it in patients with neuroendocrine tumors. And I think it's important to discuss it always with your treating physician, and what is our goals of care as well, because there are many different medicines that can help us to control the diabetes, and there are other very good medicines such as metformin and so forth. But at the same time, Ozempic and Mounjaro is something that needs to be discussed in detail with your treating physicians. We don't know what will be the long-term effect, whether it can worsen the neuroendocrine tumors or not. We don't know, but in that case, we can always discuss it with your treating physician whether it's adequate for you to be on any of those medications. Hypothyroidism. Hypothyroidism is a deficiency of thyroid hormone. So there are drugs that we have used for the treatment of neuroendocrine tumors, such as the tyrosine kinase. The tyrosine kinase inhibitors are the type of drugs that block the blood vessel supply going into the tumor, and we have 3 of them that we have used in the treatment of neuroendocrine tumors, such as sunitinib, lenvatinib, and cabozantinib. And also because it also lowers the supply going to the thyroid as well. So, and because of that, there is a risk to develop hypothyroidism or deficiency of thyroid hormone. And in some of the studies, it can be as high as 85% of patients out on these type of medications that can develop thyroid dysfunction. And because of that, it's important that the patient, whenever is going to start on this medication, we can obtain a baseline thyroid function test and then also monitor and repeat accordingly and according to symptoms. And the reason why is because some of these patients may have very specific symptoms that cannot sometimes, help us. We need to understand, because sometimes it can be confusing because a patient have excessive fatigue. Is that because of the treatment, because of the neuroendocrine tumor, because of the deficiency on thyroid hormone? And that's something that we need to recognize as well, and do the proper measurements and obtain the blood tests as well as treat it early. The injections such as somatostatin agonists and very small and less than 1%, it can also cause thyroid dysfunction too. So we know, as we discussed, medication that has been used for the treatment of neuroendocrine tumors such as sunitinib, lenvatinib, cabozantinib. Very rarely the injections such as somatostatin or agonists such as lanreotide or octreotide can cause thyroid dysfunction. And what is the symptoms of hypothyroidism? Some of the symptoms, it can also increase weight because the thyroid hormone is important for metabolic functions in the body. So you don't have enough thyroid hormone, then the patients start gaining weight. They feel very fatigued. They have cold intolerance. They feel depressed. They start losing their hair. They have brittle skin. They can also have constipation because, like I say, thyroid hormone is important for the metabolic functions of your body. If you don't have enough thyroid hormone, like your metabolic rate is very slow, and sometimes you have all these different symptoms. And like I say, it's important to recognize, because sometimes when a patient may discuss with their treating physician, well, I feel in a very fatigued, sometimes is this because of the cancer diagnosis? Is because of the treatment? So, and that's why if our patients are on this medication, it's important to obtain the thyroid function test to recognize the symptoms early, because this is something that can be easily treated. And the way we treat it is to give what is missing. And this situation is give the thyroid hormone replacement. And the way we give it is with levothyroxine. And it's usually the dose of levothyroxine is usually calculated based on the height and weight. Every patient may have a different dose of levothyroxine. So in summary, 10 to 30% of patients with pancreas neuroendocrine tumors secrete hormones, resulting in clinical syndromes. Mid-gut neuroendocrine tumors, small bowel neuroendocrine tumors may develop carcinoid syndrome. Bronchial, thymic neuroendocrine tumor may develop Cushing's syndrome, which is, as we discussed, is because there is a hormone that is produced specifically by the tumor that stimulates the cortisol in the adrenal glands. And as I say earlier, additional measurements are needed to control the excess of hormone. Biochemical assessment in relation to the clinical presentation and adequate imaging studies will need to be done. And as I said earlier, depending on what hormone the tumor or the neuroendocrine tumor produces, there are other additional measurements that will need to be implemented in order to control the symptoms related to hormone excess. The injections, such as monthly injections, such as endostatin lanreotide, is needed for the treatment of hormone excess as well as the treatment of tumor control, but in certain situations may also either cause diabetes in certain situations, and less than 1% very rarely may also cause thyroid dysfunction. So it's important that we recognize the side effects of the treatments that we give for neuroendocrine tumors. Everolimus is another one that can cause diabetes because, as I say, inhibit the secretion of insulin. We discussed about the different tyrosine kinase inhibitors that is now very commonly used in the management of neuroendocrine tumors, such as sunitinib, lenvatinib, cabozantinib, which can often cause hypothyroidism. Important to obtain thyroid function test at baseline, and then also repeat it at any 4 of 12 weeks during the treatment, or maybe when the patient has an exacerbation of symptoms, important that they need to check this, because this is when it's happened, it can be easily treated and patients feels a lot better, improve quality of life. And it may not necessarily be the diagnosis of neuroendocrine tumors or the treatment that the patient is receiving. It may be a side effects of the treatment. In advanced metastatic disease, we discussed we have different tools in our toolbox, such as octreotide, lanreotide, debulking surgery, liver-directed therapies, PRT with 177 lutetium dotatate, chemotherapy, other therapies such as everolimus, sunitinib, cabozantinib. But as I said earlier, it's not like one size fits all. Treatment is personalized from patient to patient based on the different clinical manifestations and presentations of the neuroendocrine tumors, and based on these different characteristics and clinical findings, that we can personalize the therapy from patient to patient. And that's why we always say it's important to see a neuroendocrine tumor expert, because that can definitely tailor a treatment adequate for your tumor type and also how the tumor is seen on the scans as well. And with that, I would like to thank you for your attention. Thank you, NCAN, for allowing me to discuss about the endocrine management of these different hormone excess as well as hormone deficiency. And please continue seeing this wonderful podcast that NCAN is organizing with you. It's full of information and certainly a lot of things that we can learn, especially for the newly diagnosed. This is a very good resource for patients. And I'm always here. If there is any questions, please don't hesitate to reach out, and you can email the NCAN team to get in touch with me. Thank you so much and have a nice day.